to a brand new state-of-the-art brain and mind care facility here in Chennai. Brain stimulation to psychological therapy, Ayurveda to yoga, cognitive stimulation to naturopathy, physical, occupational and speech therapy, we are the pioneers and innovators of integrative care for the brain and mind.
Welcome to Buddhi Clinic. Neuropsychiatry as a specialty is one that affects the brain and mind interface. And when we say brain, we know we have an organ there. But when we say mind, we touch our hearts, we touch our heads. The mind is really just the software in our brain, the millions of nerves talking to each other through chemicals. What do we have in our armamentarium to treat these patients? We have surgery for some, medication for many, if not most. But beyond all that, what do we have? And what we do have is rehabilitation, therapy, and care. Now, usually a person with a neuropsychiatric condition will have to go to various places in order to receive these treatments. Imagine if you could get all of them under one roof. Imagine if you could, just by traversing floors, meet experts in every one of these disciplines who are programmed, prepared, and equipped and qualified to help you. And that really is what we offer you here at Buddhi Clinic. The opportunity of blending modern science and ancient wisdom, the opportunity of being able to receive a very wide array of care treatments that can help you. So do come, visit, see what we have on offer, and I'm sure you will not be disappointed. In fact, I'm sure you'll feel exhilarated by what you see here. Thank you.
The basement house is the state-of-art neuromodulation. We have repetitive transcranial magnetic stimulation, transcranial electrical stimulation, which comprises of TDCS, TSES, pulsed and random noise stimulation. We have transauricular vagus nerve stimulation. Along with the neuromodulation, we have yoga and mindful suite, as well as the mind labs, where we are following the traditional as well as the modern way using the computerized models of assessment and therapy.
Welcome to the Neurodiagnostics Lab. So this suite is well equipped to run all our electrophysiological assessments. So here we do the EEG, the nerve conduction studies. We also run the autonomic tests. And here you can see the tilt table, which is used to do part of the autonomic testing. This suite also has a state-of-the-art sleep lab. It's a very comfortable space where patients with sleep disorders have an overnight polysomnography, that is the sleep study. So you can see that this is a suite which is very well equipped to run all the neurodiagnostic tests for patients with neuropsychiatric disorders across the lifespan. Welcome to our advanced gym facility on the rehab floor. Here we have equipment which is customized to address physical disabilities for patients with Parkinson's disease, for stroke, for traumatic brain injuries and various other neurological disorders which cause a lot of distressing physical disabilities. These are our mobility lab suites, a part of the rehab floor. And here our well-trained and expert physical therapists deliver interventions such as electrotherapy, manual therapy and exercise therapy for patients with pain, balance and posture issues and autonomic symptoms, among various other physical symptoms of neurological disorders. This is our Dr. Deepa Krishnan Neurodevelopmental Therapy Suite. And here our physical therapists work with children with neurodevelopmental delays. On the rehab floor, we have the speech and language therapy suite, where our speech and language pathologist delivers speech interventions and swallowing maneuvers to children, adults and elders with speech and swallowing disorders. The second floor is dedicated to holistic care. So we have the complementary and alternative medical treatments. So here we have 2 dry therapy suites where we do acupressure, reflexology and meridian massage. And here we have 3 wet therapy suites where we do treatments with medicated oils, powders, with foments, and we use mud packs, after which the patient can go across to the bathroom and have a bath. And these treatments are used for a host of physical, cognitive, and behavioral symptoms which are very common in neuropsychiatric disorders.
Hello and a warm welcome to all my lovely audience present today. Thank you all so much for joining in on a bright Sunday morning. Just like how we take care of our physical self, our brain also sometimes needs that pampering. Today we are here to do exactly that. My name is Hiba Marim, and it is my pleasure and honor in welcoming you all to the webinar on emotional brain and unquiet mind, managing the nexus, brought to you by Buddhi Clinic under the Hindu Wellness Series. We are elated to have with us Dr. Ennapadam and S. Krishnamurthy, behavioral neurologist and neuropsychiatrist, who's also the founder of Buddhi Clinic. We also have Vivek Mishra, Director, Clinical Neurosciences and Neurotechnology, Buddhi Clinic. A warm welcome to both of you, and thank you all so much for joining us today. So, without holding up further, let's get this webinar started. First up, we have Dr. Ennapadam S. Krishnamurthy, who will be addressing the gathering. So, Doctor is a behavioral neurologist and a neuropsychiatrist, the founder of Buddhi Clinic and NeuroCrish Foundation. He is a pioneer of integrated and holistic health and rehabilitation for the brain and mind. He has taken on multiple international leadership roles in the clinical science and treatment of epilepsy, dementia, and neuropsychiatric disorders. He is the immediate past president of the International Neuropsychiatric Association and the editor of the Global Approach series for Cambridge University Press and Neuropsychiatry Across Cultures for Oxford University Press as well. He has to his credit 70 plus scientific papers, 30 plus book chapters, and over 25 articles in the lay press, and has lectured widely across 4 different continents across the world. He will now be addressing us and giving us an introduction to the concept of emotional brain, and also discuss the links between brain development, brain degeneration, and a lot more. So over to you, Doctor.
Good morning. I hope you're audible. We're going to share screen and go with our presentation. So we've titled this The Emotional Brain and the Unquiet. We've titled this The Emotional Brain and the Unquiet Mind. And the idea is to talk about the links between the brain and mind when it comes to emotion, both the genesis, the regulation of emotions, and of course, their expression as an unquiet mind, as symptoms of mental health. Next slide. What we are talking about is context-wise like this. The brain is our hardware and the mind is our software, very similar to a computer. The brain is nothing but millions of nerve cells talking to each other through chemical connections that make up the mind. We have a pretty picture of MRI tractography showing you how connected the brain is, and the working brain really is the mind. And therefore, disruption in these pathways and signaling is what results in mental health symptoms. Next slide. Now, what constitutes our emotional brain? The key structures here are called the limbic system. They form the oldest parts of our brain. If you draw a line between your ears, you have the hippocampus and the amygdala. The hippocampus functions as a comparator of information and a storehouse of memory. The amygdala is an essential point for cognitive representations and emotional salience. So you have a memory hothouse and an emotions hothouse in your brain. And this is the oldest part of your brain. Notice how it's connected with smell
And that's why even the lowest mammals have smell memory. The next slide, please. You can see here how the brain evolved over time. So the reptilian brain became the paleo-mammalian brain and then the neo-mammalian brain over time. And this evolution also has been enriched by chemical-rich pathways that go across the brain, the limbic system, but the brainstem and the cortex are also supplied by a range of neurochemicals. The next slide, please. Paul MacLean said that the history of evolution of the limbic system is the history of evolution of the mammal, while the history of evolution of the mammal is the history of evolution of the family. Now, if you think about that, human emotions have developed as we have become a society, as we have become families and communities. And one of the most important human emotions is empathy, the ability to feel for your fellow man. And that ability of empathy is part of this development, emotional development of our brain and of the limbic system. And that's very important to understand, because one of the things that happens to people when they start experiencing mental health symptoms is that they find empathy hard. The next slide, please. Please also understand that our limbic brain leads to our typical fight, flight, and freeze response. And this cartoon illustrates that very well. The eyes are seeing a snake. Now that information is communicated through the thalamus, which is a very important structure in the middle of our brain, and the visual cortex to your memory and emotion centers. The hippocampus, which recognizes that this is a snake and tells you that this is dangerous, and the amygdala, which leads to an outpouring of emotion. Now, it's that outpouring of hormones that enables you to either fight the snake, run away from it, or you freeze. And accompanying this are what we call autonomic symptoms, because what happens is that your heart rate goes up, your blood pressure goes up, and your muscles suddenly get an outpouring of blood that enable you to either fight or fight or flee. And this is the mechanism. It starts from your emotional brain. The next slide, please. Now, the limbic brain adds together with our neocortex, the newer parts of the brain, unique to higher mammals, unique to human, to give us that sense of self. And what MacLean said was that without a co-functioning limbic system, the neocortex lacks the requisite neural substrate for a sense of self, of reality and memory of an ongoing experience, and feeling of conviction of what is true and what is false. I want to contextualize this specifically for mental health. It's not just having emotions, it's being able to have that sense of self that helps us be purposive, it helps us preserve our mental health. And a core mental health symptom, if you think about it, is losing one's sense of self, losing one's understanding of what is real and what is just perceived. And many mental health symptoms, especially serious mental health symptoms, arise from this loss of sense of self, for which both the emotional limbic brain and the cortical structures which contextualize those emotions are very important. The next slide, please. So there is a lot of brain and a lot to mind. 86 billion neurons with 100 trillion connections make up our brain. Different designated brain areas have different designated brain functions. But the working brain requires considerable crosstalk and effective communication. And as I was saying earlier, your working brain really, therefore, is your mind. The next slide, please. Now, what about the unquiet mind? And we'll start by learning from epilepsy, which is a very important neurological disorder, or one that also affects the mind. Next. Now, temporal lobe epilepsy is what arises from the limbic system. And one of the things that it causes is a long-standing change in behavior, what's called the Gustav-Geschwind syndrome. And what do these people have? They have an intensified emotionality, which is also very labile. They can be very viscous, which means they find it very difficult to terminate conversations. They tend to be excessively orderly. They tend to hyper focus on details, and they tend to be excessively persistent. They have a decreased interest in matters sexual. They have an increased interest in matters religious or spiritual, and they can be hypergraphic in that they write a lot, but not necessarily creatively. The image here shows you how the brain changes when a person is affected with TLE and how the emotional brain lights up when you have a condition like TLE. The next slide, please. Now, Baer and Fedio made this very interesting proposition. Why does behavior change like this in people with chronic temporal lobe epilepsy? They said that your temporal lobe has increased electrical activity when you have epilepsy, temporal lobe epilepsy, and this results in an enhanced connection between all your sensory inputs, all that you see, all that you hear, all that you smell, all that you taste, all that you feel, and how your emotional brain is processing this sensory input. And therefore, all your sensory in experience gets suffused with emotional coloration. So you start making connections that are not warranted. And this was a hypothesis, which is a very interesting hypothesis, but kind of holds good when you think about the kind of problems behaviorally that people with temporal lobe epilepsy can face. And please remember that it's not everybody with temporal lobe epilepsy, but many people with temporal lobe epilepsy, especially when it's chronic. The next slide, please. Now, a very good example of this was Vincent van Gogh, the very famous painter. He had both an emotional brain and an unquiet mind. He did suffer from seizures, but he also had hallucinations. He had mood swings. He had explosive, impulsive behavior, and quite typically some of the personality traits which are associated with temporal lobe epilepsy. He was hypergraphic in both letter and painting. There was one time when he produced 200 paintings and 200 watercolors, and literally one every 36 hours, and managed to write to his brother Theo 200 letters, filling 1,700 pages, the shortest of which was 6 pages long. He had intense mood swings. He was prone to irritability and anger. He demonstrated a spectrum of sexual behavior. And during an argument with Paul Gauguin, that is when he had the sort of biblical injunction that if thine offend thee, pluck it out. And he plucked out his ear. And this is the portrait of the man with the bandaged ear, the self-portrait that he went on to paint. Please remember it was done looking at a mirror. So the affected ear was the other one, a little bit like Trump. The next one, please. Now, does epilepsy or does behavior in any way explain brain dominance? And Baer and Fedio in that famous study went on to point one more thing. They found that their patients with a right-sided focus to their epilepsy were more emotional, more prone to elation and sadness, and had a better image of themselves than what the relative, their caregiver, usually the spouse, reported. So they thought better of themselves than the spouse thought of them. On the other hand, people with a left-sided focus tended to be more ideative. They had a greater sense of personal destiny. They had more philosophical interests, and they thought less well of themselves than the relative thought of them. And this kind of gives you an idea as to how left and right brain dominance is also affected when you have a neurological disorder that affects either the left or the right side of your brain. And of course, that left and right brain dominance can give you various tendencies. The next slide, please. Now, is there proof? Because that's something, we live in an era where everybody wants proof. Now, this is Kumagasu Minakata, a Japanese naturalist. He never acquired a formal degree. He went across about 20 universities in the US and Europe. He wrote hundreds of papers on religion, folklore, and natural history. The Emperor of Japan was so impressed with him that he gave him a grant to build the Minakata residence. He was actively involved in the anti-shrine consolidation protests and the nature conservation movement. He was hyposexual. He was a virgin until age 41. He was hypergraphic. He wrote minuscule letters in compact space and a tremendous number of articles. And he was considered intense, emotional, short-tempered, and irritable. Now, this sounds just like Van Gogh, but there was a difference. His brain was preserved for posterity, And Murai, a neurologist and colleagues, they did an MRI imaging of his postmortem brain and showed that he had a small right hippocampus. A small right hippocampus, as I'll be telling you, is associated with various forms of temporal lobe epilepsy, but also with the kind of behaviors that we've been talking about and with other things. The next slide, please. So what we have come across is, when you collate the information, a smaller hippocampus in MRI studies appears to be associated with schizophrenia-like psychosis, including psychosis that comes with epilepsy, but not just epilepsy, but also with schizophrenia itself. A smaller hippocampus is also associated with unipolar depression, which is people having just major depressive episodes without any episodes of hypomania or mania. On the other hand, and I told you, if you remember, that the hippocampus is your comparator of information and your memory center. On the other hand, a preserved amygdala, even though the hippocampus has been atrophied, in the same person, when the amygdala is preserved, it seems to make them vulnerable to a bipolar disorder or anxiety. And this includes people with epilepsy as well. And when other temporal and extratemporal gray and white matter lesions develop, or there is volume loss, all other forms of psychosis other than schizophrenia seem to represent themselves. So we have evidence from MRI that various mental health conditions seem to originate from specific brain regions, or certainly they seem to have an impact on specific brain regions. This is a little bit of chicken and egg. We don't know whether it's the problem with the brain region that's leading to the symptoms, or indeed it is having the symptoms that leads to the brain region, presenting in a certain way. But this is evidence that your emotional brain is affected when you have mental health symptoms. The next slide, please. I've written about this in an editorial for the Journal of Neurology, Neurosurgery, and Psychiatry. Next slide, please. Now, I come to a very important aspect. If you think about it, so therefore, is it only the limbic brain that is responsible for emotions? The clear answer is no. Now, Luria, a famous Russian neuropsychologist, talked about three functional units in the brain. The first was the unit for regulating tone and the waking and mental states. This is your brainstem and your limbic system. Then he talked about the unit for receiving and analyzing and storing information, which is a lot of your brain, especially the parietal lobe. And then he talked about the unit for programming, regulation, and verification of activities, which is primarily your frontal lobe and prefrontal cortex. Next slide, please. Now, the best lessons we learned about the frontal lobe were from this famous case of Phineas Gage, who was a railroad worker who was, involved in blasting for the railroad. And that long iron rod that you see him carrying, it dislodged itself during a blast and embedded itself into his skull in the way that you see, going through the orbit, the eye, and going through the front of his brain. What was well described about Phineas Gage was that while he survived miraculously this accident at a time when people did not have the best medical care, he was no longer Gage. A responsible and socially well-adjusted person before the accident became capricious, vacillating, and impatient of restraint. So he underwent a personality change. And for many years, the frontal lobe had been thought as the silent lobe. People thought it had nothing to do. This was one of the examples that made people realize that the frontal lobe is really important for regulating human emotion. The next slide, please. Now, the prefrontal cortex, as I said, was considered the silent lobe. It's even been the site of lobotomies for psychiatric disorders. And it's only in recent times that we've become aware of its importance for a range of cognitive and behavioral conditions. And of course, very importantly, Vivek's going to be talking to you about brain stimulation shortly. It is the site of a lot of brain stimulation that we do. We influence the mental health by stimulating the prefrontal cortex, and you'll be hearing more about that. The next slide, please. Now, different parts of your frontal lobe cause different kinds of symptoms. So, for example, the dorsolateral, which is the top of your brain, results in having executive function or working memory and planning difficulties, perseveration, doing or saying things repeatedly, stimulus bound behavior. For example, you put a glass in front, a spectacle in front of somebody who has this problem, they'll just take it and put it on, whether or not it belongs to them. And problems in finding words. If the base of the brain, the orbitofrontal cortex, is affected, you become disinhibited, which is what happened to Phineas Gage. You have inappropriate mood and affect. Affect is your mood as other people see it. You have impaired judgment, and you're very distractible. And if the middle of your brain is affected, the medial parts of your brain are affected, you become apathetic, you become mute, you develop a certain kind of aphasia where you understand but you cannot speak, and you become weak in your legs and you become incontinent. So many functions are affected when your frontal lobes are affected, and the frontal lobe has a lot to do, therefore, with our behavior. The next slide, please. We also know that there are very specific differences between, say, being depressed and being apathetic. People who are depressed have low mood and crying spells. A person with apathy or abulia, which is lack of will, as in stroke or traumatic brain injury or Parkinson's disease, their mood is seemingly unaffected, but they are apathetic. They'll sit for long periods of time in front of the television and not even change the channel. The relative often says that I put the remote in his hands, he didn't even change the channel. A person with depression has an inability to experience emotions, which is called anhedonia, or show interest. Whereas the person who's apathetic has no interest and no motivation. So Professor C.D. Marsden, a very famous neurologist, one of the best published neurologists, describes a patient who lived in front of a golf course in order to play golf. But once he developed Parkinson's disease, he would sit on his veranda, he would watch golf being played in front of him, but he never had the will to get up and go and play it. So he described this as the golf test. Then, of course, when you're depressed, you're distressed by the experience and you try to seek change. Whereas people with apathy are not really affected. And apathy is therefore a very neurological symptom, whereas depression, of course, is much more a core mental health symptom. And it's very important to make these differences in clinical practice, because very often what is apathy is mistaken for depression, and vice versa. The next slide, please. The other thing that we see with frontal lobe dysfunction are problems with managing emotions, disinhibition, or what's called emotional incontinence, my inability to control. So very often there is inappropriate laughter or inappropriate tears, but that really doesn't come from the heart. It is just an inability to control one's emotions. So in such people, any form of brain injury, it's been described with multiple sclerosis, been described with traumatic brain injury. It's seen in various forms of dementia, including Alzheimer's disease. It is seen in strokes very commonly. They have normal baseline emotions, but their episodic emotional responses are very hair trigger and excessive. And very ordinary things like, hello, Mr. So-and-so, how are you, can cause the person to break into tears, seemingly. And this is a very classic problem that we see with brain injury. The next slide, please. Hypersexuality is another problem that we see with various forms of brain injury. It is seen, it's a very important symptom in frontotemporal dementia. A young person who seems to be changing, when I say young, in their 40s or 50s usually, in whom behavior is changing dramatically, and they go from being well-respected individuals to someone who is behaving most inappropriately and demonstrating the most inappropriate emotions. Such people, for example, can even display, for example, sexual intent towards a younger member of the family. Now, this is seen in frontotemporal dementia, but it can be seen also in Alzheimer's disease and other forms of dementia. It can be seen in various forms of brain injury. So when the frontal lobe is affected, you get many such symptoms that we are talking about. Next slide, please. So in summary, I'd like to place in front of you that we have an emotional brain, and our emotional brain is what leads to an unquiet mind. Memory and emotion are closely linked. Both have genesis in the limbic system, which is our evolutionary brain. Our psychomotor impulses as human beings emerge from the limbic system and are mediated through chemical-rich pathways. Our prefrontal cortex and the limbic association areas modulate the expression of these impulses, and our learnings have largely come from neurological dysfunction, but new technologies are teaching us how normal brains function. Next slide, please. Luria's hypothesis, therefore, that it's either an enhanced limbic outflow or an inefficient frontal control that leads to our having mental health symptoms is probably correct. And the next slide. Our limbic brain acts together with our neocortex to help us possess the sense of self. And one of the things that we lose when we have a major psychiatric disorder is our sense of self. And I'd like to remind everyone and close by saying that our emotional brain being linked to our cortex is what leads to us being uniquely human. And that's the importance of understanding emotionality and the brain and mind. I'm going to now pass on to Vivek Mishra to talk about brain stimulation.
Thank you very much, Doctor, for sharing your thoughts on that topic. Let me now introduce our next speaker in this amazing webinar. Before that, I request all the audience, in case you have any questions, you can put them up in the Q&A box. And towards the end, our experts will answer them for you. So please make use of that opportunity. Next up, we have Mr. Vivek Mishra. He has completed his MS Clinical Neuroscience from the Faculty of Medicine, University of Madras. He's also done his fellowship in brain stimulation from Rambam Healthcare Campus, Haifa, Israel. He's also the assistant editor of Cambridge University Press series, A Global Approach, Dementia and Epilepsy. He is elected as a life member of the Indian Academy of Neurosciences and the Indian Epilepsy Society. He is also the director and executive committee member of the International Neuropsychiatric Association. He will now be addressing us on how modern neuroscientific technology is advancing care for individuals with various neuropsychiatric conditions. Over to you, sir.
So good noon. So now we have already heard about the hardware, the brain, and the software, the mind. And then apart from the emotions, what else these connections brings out? To put up a context, when we talk about, so brain is a symphony. Our brain is an orchestra which have a complex networks of neurons conducting a music of our thoughts, emotions, and actions. And now when this symphony gets out of tune, the behavioral, psychiatric, and neurological condition arise. For example, in depression, anxiety, OCD, seizures, etc. So what are the challenges? So the medication and other therapies are valuable, but sometimes they are not enough. Some side effects and the limited efficacy can hinder the traditional treatments. Invasive procedures like brain surgery carry risk and not accessible for everyone. So what we do about that? We are talking about the brain plasticity. Now, our brain is not static. It constantly adapts and changes. And most of the findings, it has been shown that up to the age of 70, we still can learn and remember new things. Now, this ability is called the neuroplasticity. Now, non-invasive brain stimulation harness these principles of neuroplasticity for therapeutic purposes. If we look at our brain, there are 52 Brodmann regions which works in synchrony, and as an output, we feel the emotions as well as our behavior. Now, how do we know? As we say that there are, what is like the proof that these are the regions are involved in the behavior? So for example, when we talk about the resting, if you look, the brain changes when we walk. There are certain areas like motor cortex get activated. When we see an object or hear an object, there are different brain areas are getting activated when compared to the resting state. When we think, our frontal lobe, which we just heard about, gets activated. And then when we remember, the different brain areas are activated. So now we know that these areas are activated. What's next? So using the next generation stimulations like transcranial magnetic stimulation, In early 1900s, the idea dates back. And 1985, Professor Tony Barker and colleagues, you can see him on the right side, holding the first of the device in late 1988. We devised a plan that can we stimulate these brain regions to stimulate using the different coils. So what is transcranial magnetic stimulation? So transcranial magnetic stimulation is an established non-invasive and non-convulsive neuromodulation technique initially developed in mid-1980s as a tool to study human neurophysiology. So previously, when a neurosurgery have to be performed, a patient have to be sedated or a live brain recording have to be done, and with the advent of the TMS, we can able to spot the exact brain areas involved in that surgical procedure. Over the period of time, it got FDA approval for the treatment of depression, OCD, chronic pain, and can be used effectively in other neuropsychiatric conditions like post-stroke rehabilitation, Parkinson's, psychosis, etc. However, there are advantages. For example, it is painless, it's non-invasive, doesn't require anesthesia, general anesthesia where a patient have to come and admit, and it can be done in total and outpatient process. So our journey at neuromodulation, we started at the fellowship, what I have done in the Ramam Healthcare Center, where they were the first group to do the TMS trial for major depressive disorder in 1991. And we started in 2018, and over 6 years now, we have done over 17,300 sessions. And what wisdom we have got from these many sessions is the TMS use electromagnetic induction to generate very local electrical field in the cortex, though it does not feels like an electric shock, but it stimulates up to 5 to 6 centimeters inside the brain. And there are different frequencies, and it depends on do we want to stimulate the brain or we want to inhibit or slows down the brain. And when the TMS sessions are adjunct with the cognitive and behavioral therapy, we can prime the brain to be more responsive and reduction of these symptoms more effectively. So how does TMS work? Based on the Faraday's principle, very basic physics principle that everyone goes through in their 10th and 11th standard. So a rapidly flux magnetic field is being generated over your cortex, induces current in underlying cortex, permits focal manipulation of the cortical activity. While changing this focal cortical activity, we look there are several types of frequencies and different paradigms for a different outcome. So a patient getting a stimulation to modulate the thalamus and the OCD, it is different than a person looking for a solution of a depression, where we know that the left prefrontal cortex is overfiring. Left prefrontal cortex is underfiring, and what we do is we use the higher frequencies magnetic pulse, and if we look into the serial MR scans, that the brain is getting activated over the period of time, whereas we talk about the right prefrontal cortex, and while inhibiting that area, we find that the cortex is underfiring, and as the patient getting better. So now several studies demonstrated that the repetitive transcranial magnetic stimulation is an efficacious treatment for treatment-resistant depression. Hence, just 2008, the FDA approved it for the treatment, and even now, the application ranges up to the 85 years of a person suffering from depression. So what I wanted to show, demonstrate from these studies that just by stimulating the brain and the underlying brain networks, we can enhance our mood and emotions. And when we talk about the simultaneous TMS and psychotherapy in major depressive disorders, the clinical outcomes are quite impressive, rather than when the combination can produce up to 66% responses, and 56% patients just go totally symptom-free within the 5 weeks of treatment. And out of that, the 60% do remain treatment-free for a very long period of time. So now if we just look, just like the imaging studies are the proof that a person with depression have a low activated brain, and after the TMS, you see that there are changes which happen in the brain which activates the excitability, especially over the right prefrontal cortex. This is a video, one of the patients who gave consented to us. This is how the TMS has been done without any pain. So you see, is just having so this particular patient were having an intractable depression, and after having the TMS, she is and there it's just the monotherapy along with the psychotherapy done. And there are studies which suggest that when we use the combination of the therapies like the pharmacotherapy, the medicine, the psychotherapy, and the TMS, the effect can go up to 70% more than any of the treatments standalone. Now, similarly, when we talk about the anxiety disorders, taking the brain, the hardware as in perspective, where you can see in the patients with the obsessive compulsive disorder, the firings are different. Patients with schizophrenia, the firings are different. And the patient, which most of the times call in the schizo-obsessive disorder, where the brain areas do differ in terms of the function. So they are not structurally damaged brains. They are perfectly fine brains, but they are functionally different. And using these insights, which clinically correlates into clinical psychology, we can able to target the specific brain region using the TMS. And it's just to see there are several brain regions which we can target. And this is one of the recent studies which shown that the TMS has been highly effective for the patients with OCD. So we know is not just one area, but there are several areas. This DLPFC, we are talking about the left dorsolateral prefrontal cortex, orbitofrontal cortex, supplementary motor cortex. So there are several brain areas which are involved in this mood and emotion regulation. The story don't end with the depression and OCD alone. We have the brain stimulation methods again for a very particular brain area called the precuneus, which is a very big area, and it's been used for treating the Alzheimer's and especially the behavioral output when we talk about the Alzheimer's. Now, we stimulate the brain, we record the brain recordings using the EEG signals, and we can actually see the brain in live environment, that how the brain have changed over the period of time. And that's what the figure on the right demonstrates. Now, TMS is one, but what can go home is the big question. And to answer that is the TDCS, which is the transcranial direct current stimulation, which gently tunes the brain electrical orchestra. Now, the TDCS use a very weak electrical stimulus, which modulates the brain activity in specific areas, looking for the emotion and the output. We are talking about depression and anxiety, because now we clearly know which brain areas are affected in those conditions. We talk about the mild cognitive impairment, as we saw in the previous presentation, that the hippocampus has been used. So if the hippocampus is not firing, what we can do? We can use the TDCS to stimulate with mild electrical stimulus, which is just a 2 milliamps, which is very well tolerable from the age of 6 to the oldest person we have stimulated is 92 years of age, and found it had found to be effective. Similarly, conditions like multiple sclerosis, stroke, Parkinson's, and has also been effective in the behavioral variant. So I mentioned, like with the focus, that the behavioral aspects in autism and the kids with ADHD. So it is painless, it is non-invasive and well tolerable across lifespan, can go home as well as next to the bedside. And what it does to the brain is, if we look the top picture, that where the positive electrode has been placed, it shows that red spot. That red spot shows the activation of the brain area, whereas the blue spot shows the inhibition. While stimulating a very specific brain region, we can able to show the difference on their cognitive, memory, mood, and behavior profile. And that's not that's not it. When we talk about the TDCS, it is just a plain waveform. When we talk about the transcranial direct current stimulation, There is an alternate current stimulation which is used in patients with insomnia. It can be used in patients with Parkinson's. And there is a random noise stimulation, which is a very recent development in the TDCS domain, the electrical stimulation domain. And the output people are like various labs finding in vertigo and migraine. Next. Now, how we can use the TDCS in order to enhance the output in adjunct with neuropsychotherapeutic interventions? The treatment protocols are personalized for attention deficit, hyperactivity, behavioral disorders, sleep disorders, movement disorder, memory, etc. And in the photograph, you see the kid with very severe ADHD scores. He won't able to sit and complete the task, and he is very much focused. While having the TDCS, he can able to perform the task. So it is a two-way mechanism. We are stimulating the brain and we are using the same brain networks to perform our task, strengthening our brain networks. So now when we look for the TAVN, so in epilepsy, as we started the talk with using the epilepsy as an example, if we just look, what is it a seizure? Yes or no? The EEG signals are there. Can we catch those EEG signals when the seizure is happening? Yes, that's a middle photograph. If you look, that is a blood oxygen level dependent signal. And once we know that what areas are being affected, we can use the another non-invasive modality called the transcutaneous auricular vagus nerve stimulation. A very small probe, which used to be a surgical method before 2013, is being placed on your left ear. As you can see with the left ear, the probe is being placed. Now, the TAVNS stimulates the auricular branch of the vagus nerve, a key player in regulating the body's stress response. And the TAVNS has been found to be effective in management of epilepsy, vertigo, cluster headache, dysautonomia, and regulating gut-brain axis. And recently, the new invention of the TAVNS is focused on treatment of post-acute sequelae of COVID-19. Now, many of the patients and the data suggests that the people who had COVID demonstrate or have the symptom of dysautonomia up to 24 to 36 months. And using the TAVNS, we can regulate that particular brain networks, which again connect to the brain stem. So if we can recollect, the brain stem is the area where our vital functioning of the body has been placed. While stimulating those areas connecting to the heart, we can able to see the changes. A neurofeedback, training the brain to train itself. While the neurofeedback therapy monitors your brain for the brainwave activity, it almost immediately provides a feedback. So if I ask, please focus on the book, and you say, yes, I am focusing on the book, how do you know that we are actually focusing? Now, the neurofeedback using the quantitative EEG gives us that particular feedback that it is not optimal and it can be more focused. And again, as you see the photographs, like the brain scans on the down, we can see that when we are stimulating those particular brain networks, it gets more activated. Effectively being used in the children with ADHD, children and adults with ADHD, anxiety, depression, autism spectrum disorder, insomnia, and the other advantages in the drug addiction, schizophrenia, learning disability. So while stimulating, so we have so far covered that we have stimulated the brain, we have trained the brain, but what about our spine? Because if we have an injury, like a spinal cord injuries or acquired or a lower back pain, it is giving the constant signal to the brain that there is a pain is there. Now, the functional magnetic stimulation modulates the nerve muscle bridge. And while modulating, it uses the high intensity magnetic pulses to enhance the rehabilitation process and relieve pain. Now, FMS, also known as a peripheral magnetic stimulation, the first indication was the spinal cord injuries. But over the period of time, we know as the pain research goes in detail and we see that what brain areas getting stimulated with the pain and the spinal nerves, it's used these days, the applications are in frozen shoulder, upper and lower back pain. musculoskeletal symptoms like tendinitis, fibromyalgia. Again, post-COVID, the fibromyalgia cases are on rise across the globe. Similarly, the neuropathies, and in some cases of urinary incontinence resulting from the injury. So it's not only the injury treatment, but the secondary, just like the urinary incontinence, can be treated. And everyone talks about the evidence, and there are plenty of evidence where the non-invasive brain stimulation been used in a new strategy, improve neurorehabilitation after stroke. We talk about increasing the cognitive performance in elderly patients. We talk about mild cognitive impairment, RTMS, and depression. And these areas point out to the one thing, that it's the era of a non-invasive brain stimulation, because we have understood brain in last 110 years. We know that these are the brain. We are getting the brain scans where we show the functional areas pinpointed to very relevant networks. And knowing these brain disorders allow us to precise treatment for improvement and recovery. Combining therapies like psychology, physiotherapy, medicine aids recovery. And with that, I will put it back that how we can able to.
So just a final word before we take questions. At Buddhi Clinic, what we do is combine multimodal treatments for disorders of brain and mind. We start with a very detailed assessment and analysis to understand what exactly is wrong with the person from a biological perspective, from a psychological perspective, and a social perspective. And then we offer them a combination of treatments. You've heard a lot about neuromodulation today, but we have a full house of psychological treatments. We have a full house of physical and occupational therapy. We use medication like most good hospitals do. We have, of course, a whole house of Ayush, Ayurveda, yoga, naturopathy, and a number of other pressure techniques. So there's a whole wellness program that goes alongside, and combining treatments to get the best outcome for the person is what we do. So from precision in diagnosis to precise biological approaches involving both neuromodulation and psychopharmacology and supportive therapies, both conventional and Ayush. This is the whole range. Today we have about 17 treatments in Buddhi Clinic, and we would welcome anyone who thinks they are symptomatic to reach out to us, because we think we can make a difference where other things may have failed. Thank you so much for your attention, and it's been great having all of you take part in this very well-attended webinar. Thank you. We are happy to take questions, of course.
Thank you very much for that very enlightening presentation. We have about 50 questions, I think. So let's focus on the important ones and let's see how many questions we can take in. So one of the question goes, what is the difference between brain and mind and emotions and feelings?
So I think we explained the hardware and the software analogy for brain and mind, because there's nothing inside us physically called the mind. So the mind is like the software, it's an operating system. But that operating system runs on the millions of nerves talking to each other through chemical systems. I think emotions and feelings, I think maybe we say, I mean, there's a great overlap. At the end of the day, if you think about it, it is what you feel and how you express it. That's really emotion and feeling. There is no great difference.
Right. Thank you very much, doctor, for answering that question for us. The next question goes, is mental health disorders coming in an adult genetic, or are there other factors involved in it? Is there any cure for it?
So the way to think about this is that we all carry vulnerabilities within us. So if you take, for example, diabetes as an example, you carry the vulnerability to develop diabetes right through your life probably. Your lifestyle may contribute to you expressing it at some point in time, early in adulthood or late in adulthood or in old age. So the same analogy can be used for mental health. We carry vulnerabilities. Our expressing those vulnerabilities is very dependent on what we go through in life. And of course, people who go through traumatic experiences, people who are experiencing difficult circumstances are much more vulnerable to express those vulnerabilities than people who don't. If you have a very loving, protective, and caring environment, Even if you carry the vulnerability, you may not. And to ask about treatment, it's very important to know this, that a very large proportion of mental health conditions are eminently treatable and don't ever have to come back. So it's very important to think about mental health like you think about an infection. You work very hard to treat it, and you work very hard to help the person get better. That's very important. Half-hearted efforts are not good enough. So I often tell my patients, I'm like a general going out to battle. I will use every tool that I can possibly put on the table, because that's important. That approach is important in order to help people get better. Of course, in a small proportion of people, symptoms tend to be intractable and don't settle easily or can be recurrent, but that's the smaller proportion.
And with that, we'll proceed to our next question. It goes, Van Gogh had seizures and produced an incredible volume of paintings and letters. How life-threatening is seizures, and do we all have the capacity to excel?
The last question, yes, we all have the capacity to excel. I think that's very important to know. Seizures are very treatable, and seizures should not become life-threatening, but untreated seizures can become life-threatening. So it's very important not to take seizures lightly. Okay, I think we used Van Gogh as an example to say that you can have mental health symptoms and be challenged, but that doesn't stop you from being exceptionally creative or very good. And I think, there's a lot of stigma around mental health. I hope that people understand it comes from the brain. There should be no stigma. You don't get stigmatized because you have asthma or diabetes. Why should you be stigmatized if you have mental health conditions? So I think it's very important to not be stigmatized. It's also very important to remember that people have inherent potential and they need to express their potential no matter whether they are affected with a mental health condition or not.
Yes, very true, sir. I agree with that. Move on to our next question. It goes, what is the way to address autism, especially in teenagers? Particularly, we refer to an adopted female child who was found to have such a condition. What are the chances of a normal life?
Okay, I'll get Vivek to first talk about how autism can be treated with brain stimulation, and then I will talk about the rest of it.
Done.
So now, if we look about the autism, and it's been now widely classified as the brain network disorder. So the networks which are getting, which have got stimulus in the development phase from the first month to the 6 months, they develop at a faster pace where the stimulus has not been so great, and there are of course there are some genetic factors which is also contribute to it. Now, stimulating the networks which are not being developed using the non-invasive stimulation like the TDCS, so we are stimulating those particular networks. Now, we have stimulated it and using the combination techniques like the psychotherapy, the neurodevelopmental therapies, the CBT behaviors. So we are looking from the brain and the behavior bridge. We stimulate the brain, we are working on the behavior, and especially the social behavior, the repetitive behaviors, the self-harm, self-injury behaviors in autism. Sometimes the kids with autism are little bit more aggressive. Those things can go like controlled very well while changing.
If the family does nothing, the parent does nothing, the child develops at a completely different pace from his or her peer group. When we work with children in a consistent manner, apart from brain stimulation, obviously they all need behavior therapy, they all need neurodevelopmental and occupational therapy. Many of them benefit with Ayush interventions because they have problems like sleep difficulties. Apart from behavior difficulties, they have gut health issues. Those things do very that we use constantly in Buddhi Clinic. And with all this in place, with consistent therapy, the person with autism can do well. They could have challenges in terms of, persistent challenges. But on the other hand, if you unlock their potential, many people with autism can actually find their potential. So I would say to the parent, it's very important not to give up. It's very important to work with multimodal treatments. It's very important to be consistent. and it's very important to find the right resources.
Yes, thank you very much, doctor. That will surely help the person whoever questioned this. We move on to our next question. It goes, hello, sir. The advanced treatment options provided at your clinic are great, but how can these be more accessible to patients in tier 2 and tier 3 towns and villages?
Okay, so the good news is that the government of India has introduced neuromodulation in all the All India institutes now. Okay, so it is slowly, technology is slowly penetrating across sectors. I think that's very important, but I think it's a very pertinent question. It is going to take some time for smaller towns and certainly for villages to be able to access neuromodulation or modern technology, and I think that's true of all healthcare. But that's something that we have to keep in mind that it will take time, but that doesn't stop us from helping people. So I think the most important thing to keep in mind also is that we can do a lot of work online today thanks to the pandemic. We actually have a whole program called Buddhi Online. We work with people in rural areas also through this program, and we intend to set up our first rural center outlet in the next month or so. So, in a sense, we believe that we cannot take all the modern technologies out, but we can certainly take care out to people. And I think it's very important to make sure that people get care.
Yes, absolutely, sir. Thank you very much for answering that question. We will move on to our next question. It goes, speaking of magnetic stimulation, how helpful is it for a person with 35 years history of OCD and also suffering from minor mini strokes causing flashes of darkness and associate headache in the left eye region?
Okay, so there are two components. So when we talk about the long-standing intractable disorders, recently we had a person who had depression since the age of 23 and he is now 61. So he came up with a 40-year history of depression where the person have explored the ECT, the shock therapy over in last 40 years twice, and he remained symptomatic. And after the FDA approved protocol, which is about 30 sessions of TMS, he have gone into remission, which means there is no symptom, and he have taken up a outstation job also where he is traveling, and and now he is in our 1 year follow up, and he remains symptom free. So in some of the conditions, yes, the non-invasive stimulation like TMS do provides a quite efficacious solution which is sustainable. But we have to see, as we said, the previous question was the capacity building. It is not one shoe fits all. The every modulation protocols are customized and it's tailor made to see what is going to help the patient most. And if there are some comorbidities, we have to explore those comorbidities, that it should not interferes with the normal action. So if there are microstrokes and all, it have to be investigated in detail. And then, of course, there are options in terms of the pharmacotherapy as well as the stimulation methods.
I think just to wrap that up, I would also say that hence a comprehensive multidisciplinary assessment is very important for a person like us. We are never faced by the length of symptoms or severity of symptoms because we believe that we can help. But we need to understand how suitable the person is for specific interventions, and then then plan for that person. But there is something for everybody. It's just a question of identifying what it is that works.
Absolutely, sir. Thank you very much for both of you for sharing your thoughts on that. Our next question goes, is there any difference between clinical ADHD and the ADHD that's being popularized in social media? If yes, in what ways?
So first of all, you should never self-diagnose ADHD. That's a gross error. ADHD is not, there are terms like ADHD and post-traumatic stress disorder that people use very loosely. It's become very popular to use those terms loosely. Those are very specific diagnoses. So to diagnose ADHD, we don't do it through a conversation. We actually put the person through cognitive tests. We put them through symptom checklists. We do some brain mapping. We use a lot of assessments in order to definitively diagnose ADHD. So please don't self-diagnose, and please don't let anybody diagnose this for you in a 10-minute conversation. even a specialist. It doesn't work. Okay? So I think it's a serious diagnosis because ADHD can be helped. If you really have ADHD, there are drugs that can help ADHD. There are psychotherapeutic techniques that we can use to help the person with ADHD, and there's a lot of brain stimulation that can help the person with ADHD. All our people with ADHD do QEEG neurofeedback to sharpen their brain. So there's plenty that can be done, but the diagnosis has to be confirmed.
Yes, thank you very much, Doctor, for sharing your thoughts on that. Our next question goes, what are the ways one can find out whether they are left brain dominant or right brain dominant?
So left and right brain dominance is more conceptual and philosophical rather than hard science. There are some indications that tell us that a person may be left brain dominant or right brain dominant, but in the popular view in neuropsychology is that the vast majority of people use all of their brain and therefore both sides of their brain. Okay, I used that to point out that when you have neurological dysfunction, you can demonstrate specific behaviors and specific personality traits which seem to lateralize with dominance. And this is something that we see even after stroke. This is something that we see after traumatic brain injury. It is something that's been observed, for example, in MRI research. For example, the left hippocampus being atrophied is much more associated with both schizophrenia and depression than the right hippocampus. Okay, so there is some laterality that comes out. And similarly, a lot of people, so religiosity, for example, hyper-religiosity, for example, I was part of the team that published the first paper to show that it is associated with the small right hippocampus. So there are laterality findings, but left and right brain dominance is more philosophical and conceptual rather than hard science.
Thank you very much, sir, for answering that question. We'll take 2 or 3 more questions. Next question goes, unexplained insomnia has become more common. These patients do not respond to sedatives and lifestyle changes. What can be done for these patients?
So there are two things what we can look for. So one of course, as I mentioned in the slides, that the TACS approach is being specifically tailored for the people with insomnia. Again, the lifestyle changes do play a crucial role, like not scrolling through Instagram right through the till 12 o'clock in the night and limiting your screen time have a positive impact. But the patients, the people who are not responding to those measures, TACS is an approach. And there is another modality what I have not included into the presentation is something called the audio visual entrainment. One of the devices what we have uses the binaural beats and the stimulus light, which is being there are again we have so basically we have to increase the theta waves into the brain, and how we can able to increase the delta and the theta combination is what leads to the sleep. And using this audio visual entrainment, like one of the devices what we have is like the DVD light, a person had to come put one big headphone, put a goggle like device. It produces the sound and the light wave, and the people do fall asleep, and it regularizes it. So it is not that it's focusing on changing your brain, but it is how the brain is firing and it regularizes the symptoms. And it is just can be done, 40-minute interval wherever they are.
If I can just add,
Yes,
insomnia
sir.
is unexplained. Okay, so it's either explained by your mental health or your poor sleep hygiene or by physical conditions like obstructive sleep apnea. So it's very important for people with any form of insomnia to be properly evaluated. And proper evaluation includes a sleep study. So we never accept an insomnia evaluation that is not comprehensive, because otherwise you're going to address a part of the problem, not the whole of the problem. And just putting people on pills is definitely not the answer.
Right. Thank you very much, doctor, for giving us your thoughts on that. Our next question goes, a short attention span and short-term memory loss. What could be the best treatment for the same?
Okay, so I'll tell you the clinical answer, and then I'm going to get Vivek to talk about brain stimulation. The clinical answer is to try and understand why people have a short attention span, why the person has a short attention span, because you need to attend in order to lay down a memory. And when you don't lay down memories, you have nothing to recall, which is why you have memory problems. So the vast majority of people with what we call subjective memory impairment, people walk into my clinic and say, "Doc, I think I'm getting dementia," and this is someone who's in their 40s, and it's because they're multitasking. It's because they're enormously preoccupied. They're in very busy jobs and have very busy lives, and they are failing to lay down memories. So it's very important to contextualize the attention deficit and the memory loss to the individual as part of the evaluation. I'll get Vivek to talk about what we can do for that.
So just continuing from there, that again, as we said, if the people have contracted the COVID and they are continuing to have this brain fog, so if it is not age related, there are ways to test it. Again, the neurofeedback paradigm. So it have a very specific attention tasks where we can actually measure the brain firing or communication methods and see how much is the deficit. And if there is a deficit, how we can stimulate the prefrontal cortex. Because in our executive functioning, we are talking about our planning, we are talking about our psychomotor speed, all comes from our prefrontal cortex, and stimulating it does give the leap. Again, why the person is having the the memory difficulties as well as so first we have to find it out, but there are solutions. It need not to be a neuromodulatory in nature. Neurofeedback, it doesn't stimulate just like an electrical stimulus. You are training your brain, and over the period of time, you see your brain started firing back within a normal range. So yeah, it's very subjective.
Yes, that's with this question. We'll have our last question coming up. The others who have put up your questions, you will receive your answers via email, so you don't have to worry about that. So that being said, our last question goes, does continued using of headset for music or work dampen the work of the brain, or is there a time limit in a day for usage of headset?
So the recent research suggests two things. One is listening to at a higher volume, more than 80%, do have the negative effect on the brain, especially on the auditory zone, because it's our brain getting used to those high auditory, which also damages again the auditory hardware, the nerves and other things. Second is what type of music. So there are, again, as we say, binaural beats, or we are looking for the focused music. Those enhances, there are research which suggests that it enhances our focus and attention. So we have to use it judicially, using at a low volume, and the type of music. So some people say, oh, if I hear high beat music, I'm more focused. Well, the brain don't concur with your own liking and the findings of that music. So we have to just look at what type of music we hear, and yes, using a less headphones are better.
If I can
Yes.
just,
Yes, please, doctor, please.
not about the headphones in particular. We focus today a lot on new technology, but I want to point out that integrative medicine is the future for most chronic disease, including mental health. There's no doubt about that. And while new technologies add a huge new dimension to integrative health and medicine for chronic disease, I think what already exists and is accessible to a lot of people, I want to say that psychotherapy has a huge role to play. So working with a psychologist will help a lot of patients. Physiotherapy, speech therapy, occupational therapy, and rehabilitation, all this has a huge role to play. So people who are impaired should work with such audiences, such specialists. And I would like to say that our experience with Ayurveda, naturopathy, and yoga has been excellent. We have a number of patients, for example, even with a sleep disorder or with a severe mental health condition, who do very well when they are given the right form of treatment. And very often it helps with compliance. It also helps them comply with our medication, because they find the approach much softer than having to do something that is against their aesthetic will. Okay, so I There's much to be said, therefore, for an integrative approach. There's much to be said for openness of mind. There's much to be said for blending modern science with ancient wisdom and conventional treatments. And that's what we do at Buddhi Clinic, and that's what we've perfected into a system at Buddhi Clinic. And I would encourage people to think about it that way, not be limited. Rabindranath Tagore said, where the mind has not meandered its way into narrow domestic walls. And I think it's very important that we stop having narrow domestic walls and really think openly about how we can help patients, how we can help people, and how we can help each other. I just wanted to make that point.
What a perfect way to come to the end of this webinar. We had an amazing quote, we had an amazing session. And with that being said, we have come to the end of this awesome webinar where we understood and learned a lot about the brain. A big thanks to the doctors and experts for sharing their thoughts with us. And a big thanks to the audience who have tuned in today. Usually on Sundays, we all sleep in late, but then we've all joined in to get ourselves educated. So a big thanks to all of you. All those who asked questions, thank you very much for asking those questions. All those who did not get their questions answered, you will get your questions answered via email, so you don't have to worry about that. This was the webinar on emotional brain and unquiet mind, managing the nexus, brought to you by Buddhi Clinic under the Hindu Wellness Series. My name is Hiba, and it was lovely moderating this session. Thank you all and have a great day ahead.